Hello and welcome to another episode of Onc Now, EMJ's Specialist Oncology podcast with me, your host, Dr. Jonathan Sackier. Today, I'm delighted to introduce Professor Stephen Chan. Professor Chan is the clinical professor at the Department of Clinical Oncology of the Chinese University of Hong Kong. He's also currently the president-elect of the Executive Committee for the International Liver Cancer Association. His main research interests are in hepatobiliary-pancreatic and neuroendocrine cancers, and he has played a pivotal role in several impactful clinical trials, including the CARES 310 trial and Keynote 966. Outside of medicine, he's also an avid tennis player. So, thank you for joining me on today's episode of Onc Now. Professor Stephen Chan, let's head over to the podcast. So, Professor Stephen Chan, welcome to the podcast.
Nice to see you, Jonathan.
So, the wonders of technology. I'm in London, you're in Hong Kong, and we were just having a nice chat about... it's a fascinating place because it's both, as an Englishman, I was there before the handover, and I've been back many times since. It's at one and the same time culturally very, very Chinese and very, very English. It's there's no place like Hong Kong in the world. It really isn't.
Yeah,
I
agree
love
with
going
you.
there.
In terms of food, culture, we're really the place where the East meets the West. And we do have a unique culture. So I agree with you. I still love Hong Kong. I know there's big changes from the past, but I think it's still one of the nicest places in the world.
Yeah, it's you don't want to go somewhere that's everywhere looks the same, everywhere behaves the same. But yeah, very much so. Well, I'll know who I'm going to look up the next time I'm there. So, Stephen, let's begin with the CARE 310 trial, of which you were the first co-author, a recent publication reporting the results of this trial. So, to begin, please outline the main aims of the trial for those who don't know it, and what was the rationale for combining the two drugs. By the way, I'm just going to give you a heads up. I am useless at pronouncing any drug with mab at the end. Camrelizumab and rivoceranib. You see, I can't do it. I'm just a simple surgeon. So take it away, Stephen.
Yeah, basically, it's a phase 3 clinical trials trying to look at a combinational regimen consisting of two drugs. One is Camrelizumab, which is a PD-1 immunotherapy, and the other is rivoceranib, which is an oral tablet, which is we call it small molecules or targeted therapy. And there are a lot of data suggesting that the combination of these two drugs will work well in the liver cancer. So this trial is to compare this regimen to the standard of the treatment, which is sorafenib. And we'll see the outcome of the patient, especially the survival and also other endpoints like the side effects or the response rate.
And tell us about what you found.
So in summary, it was found that the combination regimen could improve the survivals, mainly the overall survival and also the progression-free survival, which is one of the, I would say, key endpoints when we measure the outcome of the drug treatment. At the same time, the response rate is also higher. And also, we do see there are some side effects associated with the combinations, but most of them are manageable. And so overall, based on this result, this regimen has been approved in China and for the use in the treatment of liver cancer. And I know that the approval is also being submitted to some international regulatory. Hopefully, the drug will also be approved in other countries as well.
Okay, so I believe wasn't it compared to sorafenib treatment alone? And maybe you could address what some of the side effects, you said they were manageable, but it'd be nice to know what they were. And what are the clinical implications for these patients who've got unresectable hepatocellular carcinoma? And where do we go from here with that treatment therapy? I'm sorry to throw a whole bunch of questions at you, but yeah,
No
tell
problem.
us first of all about what correct. It's compared with sorafenib alone.
Yeah, in oncology world, when we manage cancer, the first thing we would like to see is it demonstrates superiority, right, in terms of the efficacy. As I already mentioned, it could improve the camrelizumab and rivoceranib could improve the survival outcome as compared to the sorafenib. And then the second objective is to look at whether this combination regimen is tolerable in the patient. We know that when you combine two drugs, instead of using one drug, usually it's associated with more side effects. We call it adverse events, or sometimes can lead to very severe toxicity. But we know that from this CARES 301 study, what we found is we do see higher rate of we call it grade 3 or above, the treatment adverse events. But most of them could be treated either by conservative manner or by sometimes if it's immunotherapy related, treated by the steroids. And most of the time it's manageable, meaning that they can resolve or subside with the withholding of the drug or some conservative management. And we also have seen some data related to quality of life. And we found that actually the quality of life of those patients treated with this more aggressive treatment, they tend to have preserved or even better quality of life as compared to the sorafenib, which means that when you talk about it, consider both toxicity and efficacy, the patient do feel better, usually because they have a better control of the cancer, but then the symptoms related to the side effects are not as severe. So overall, I would take this trial as a positive trials, and this regimen, camrelizumab rivoceranib, is one of the standard agents that we may offer to our patients with HCC.
Right. So I'm thinking back to my career in medicine and surgery, and the options for patients with various cancers that also have a surgical presentation as well as a medical one. And despite the development of new treatment options as seen, liver cancer remains a leading cause of cancer-related deaths globally. From your perspective, what are some of the most pressing challenges in both diagnosis and treatment of these conditions?
Yeah, I would say, although I'm an oncologist, I treat and see a lot of patients with advanced cancer. We still have to go back to the basic, which is prevention and early detection. In fact, we know that liver cancer, many of them actually are preventable. If you look at the causes, it's due to hepatitis B, which now that we know you can eradicate by Hep B vaccination or treat with some Hep B treatment. For hepatitis C, there used not to be many agents to treat, but now we know you have a very effective drug which you can clear the Hep C virus. And these are the two most, I would say, whether easier to eradicate. And some of behavior, like alcohol.
If I can put you on pause there for a second, Stephen, sorry to interrupt you, but I want to come on to diet in a second. Um, you're absolutely right. Hepatitis B, hepatitis C, preventable, treatable, right? But you've first of all got to detect it. Are we doing enough to screen for people at risk of Hep B and C?
This is a great point. The second thing I would like to mention is early detection. First, even in developed countries like US, Europe, they have a surveillance program for those patients with cirrhosis or high risk of liver cancer. But we know that, especially after COVID time, the default rate or dropout rate or non-compliance rate is very high. Most of the general population, even they know they're high risk of developing HCC, they may not be willing to be adhering coming back for ultrasound and alpha fetal protein every 6 months or 1 year. So the uptake rate is low. Not to mention in those more developing countries, even in Asia, not to mention Africa, the surveillance program is either not available or poorly developed. So this makes the diagnosis of the HCC very delayed in these places. And of course, this is associated with a poor outcome.
Yeah, yeah. So I guess that was a thinly shielded advertisement to our listeners to do everything in our power as medical practitioners to encourage people to get screened. I write articles for the aviation press, and I used a salutary example of an airline pilot who, an otherwise healthy man, never had any issues, And one day, whilst stopover in London, he was a commercial airline pilot. He had massive hematemesis, ended up in King's College Hospital in stage 4 liver failure, ended up getting a transplant. Hepatitis C. He'd had a blood transfusion years ago and had never been screened. So, I've been petitioning aviation medical examiners to screen for Hep C so that we can save people's lives. So you mentioned diet, you mentioned alcohol. Can you also talk about the impact of diet? And additionally, or more specifically, they're always changing acronyms in medicine. It drives me crazy. I just about learned that NASH is non-alcoholic steatohepatitis, and they go and change the name to MASH, metabolic dysfunction associated steatohepatitis. Drives me crazy. But anyway, talk about diet and MASH NASH.
We know that nowadays, probably because of better nutrition and more higher rate of the metabolic diseases now, the liver is also the organ which is affected by the metabolic syndrome. Around 30%, to your surprise, of the general population, they're having some degree of the meso nowadays. The reason why people change the term from non-alcoholic to more metabolics, because they know that even you drink alcohol, you can also develop the metabolic disease, right? So there's no point to artificially distinguish between non-alcoholic versus alcoholic. But I think the key message is, even you don't have hepatitis, even you don't drink alcohol, you still have a reasonable chance of developing cirrhosis, steatohepatitis, of course, finally HCC, if you don't control those metabolic factors. And we know these metabolic factors are modifiable. As mentioned by you, diet, weight loss, and exercise, and also control of some risk factor like diabetes, hyperlipidemia. All these contribute together to reduce the risk of liver cancer, even in general population.
Yeah. It's going to be interesting to see the impact of the GLP-1 drugs on the incidence. I mean, truly, truly fascinating talking to friends of mine who do a lot of, or did do a lot of bariatric surgery. I think they're seeing a decline, but the impact on general health and downstream consequences could be profound, fascinating. So changing the subject to a different trial, the Keynote 966, a phase 3 trial showing that adding pembrolizumab, a type of immunotherapy, to chemotherapy, gemcitabine and cisplatin. I can pronounce the chemotherapeutics. I have a problem with the immunologics. So adding it significantly improves survival for patients with advanced biliary tract cancers compared to chemo alone. Tell us about the rationale behind that trial, what it showed, and what the future holds for this kind of combination approach, chemo and immunotherapy.
Yeah, Jonathan. So we know that for generally the biliary tract cancers or cholangiocarcinoma, in old days we think they are rare cancers, but nowadays we know they are not that rare, and the incidence is rising. So the researchers and the clinicians have been looking for very effective treatment, and the old standard is still the chemo, which is gemcitabine plus cisplatin. But we know that this regimen is not particularly very effective. You may modestly improve the survival. So one of the thoughts, and also there have been some preliminary data showing that when you add the immunotherapy, the PD-1 or PD-L1 on top of chemo, first, you could improve the overall survival. You may also lead to some long-term survivors, which they may survive 3, 4, or even 5 years. This is the rationale of this Keynote 966 study, that you add the pembro to the gemcis chemo backbone versus the gemcitabine cisplatinum plus a placebo. And the primary endpoint is the overall survival. As already highlighted by you, there's improvement in the overall survival, and also the additional adverse events are, I would say, tolerable and not in the trouble. So this regimen has also been approved by, I think, international regulatory to be used as a first line for the metastatic or advanced cholangiocarcinoma.
Right. So, I mean, immunotherapy has obviously been a huge advance in many areas of medicine. I was doing a podcast just the other day with a dermatology colleague who, the advances for things like psoriasis, the implications for autoimmune conditions is profound. But in cases where immunotherapy may not be effective for hepatocellular carcinoma patient, what other treatment strategies or novel approaches are you and your colleagues exploring to improve outcomes?
So one of the key questions is for those patients who have been treated the first line immunotherapy combination like the camrelizumab plus rivoceranib or the atezolizumab plus bevacizumab when they have progressive disease. So what treatment should we use to help these group patients? At this moment, we don't have a randomized control study readout yet. So mostly the data are based on some real world data or some retrospective analysis. And also recently there have been some prospective clinical trial, single arm, to look at the use of the tyrosine kinase inhibitors, such as the cabozantinib or the nivantinib, which have been presented or published recently. And all of these studies are suggesting that when you give the TKI like cabozantinib, actually the outcome, the overall survival is around 9 to 10 months. And the again, the toxicity profile is very similar to what you are expecting from the first line use. So I would say nowadays one of the de facto standard is a TKI for these patients who have been treated with immuno. But of course, we know the biology is more heterogeneous in these group patients. Our experience is that some patients, when they have kind of a more small disease, progressive disease, they may be treated with some local regional therapy like ablation or TACE. And also for some patients, they may benefit from rechallenge of the use of the immunotherapy. This is being tested by some randomized studies. Hopefully, we will have some readout to guide us which patient to which regimen to be given which regimen, more personalized in this approach when we encounter the immunotherapy resistance.
Okay. So you're the president-elect of the International Liver Cancer Association. What key initiatives or projects for this year have got you excited? How do you see them shaping the future of liver cancer research and care? And what is there at or just over the horizon that has Professor Chan rubbing his hands with glee?
Thank you, Jonathan. I think International Liver Cancer Association (ALCA) is a very unique association, which is featured by the multidisciplinary team within the association. So apart from hepatologists, surgeons, oncologists, we also have members of the interventional radiologists, diagnostic radiology, translational science, and pathologists. So our aim is to work together to improve the standard of care for our patients. In 2025, one of our aim is to improve the education. We know that there have been many trials results, many different thoughts, very new knowledge. We would like to educate or provide a platform for different experts to circulate or exchange their thoughts or the new knowledge. For example, in June, we are going to organize a single topic conference, which is focusing on the interventional therapy, like TCE or Y90, in the treatment of not only liver cancer, but also cholangiocarcinoma. It will be held in Chicago. So this is one of the examples showing that we are committed to improve the standard by education and also by discussion to circulate the idea. And also in November, we're going to have our annual conference in Hong Kong. Again, this is a perfect time that we will present the latest findings of research, again, with aim to improve the standard of care for the patients.
And I've been to Hong Kong, and when November the weather is chilly in London, it's balmy in Hong Kong. So
It's a good idea.
I will do that. So my final question, Stephen, I like to ask all my guests: if a magical genie could grant Professor Chan 3 wishes for your area of healthcare, research, whatever, what might those wishes be?
I would say first, I really want the genie to invent or give us a drug, preferably oral, so that the patient can take one tablet and then they can have a cure of the cancer. I think this is really the dream or the hope of all of our patients. The second point is the diagnosis. If there's a tool like camera and is free of the complications, free of radiation, that you can take a shot and then we know you have cancer in whatever organ, so that we can diagnose them very early on. I think this will be very important to help remove or prevent or eradicate the cancer from our population. Last but not least, I think if there's again maybe magic syrup that if our patients with cancer could drink and then be worry free, be happy again, I hope it will be available, because I think having cancer is a really stressful experience, not only for the patients but also for the family and if or friends. So if there's something that we can really improve their quality of life, make them happy again, make them worry free, I think this will be very meaningful to our patients. So these are the three wishes.
Yeah, it's I've mentioned her before, but I had an oncologist on from New York, Dr. Azra Raza, who wrote a wonderful book called The First Cell, and it was all about detecting cancer earlier. And I have to say that, during my professional lifetime, the changes in the treatment of this disease, many of which have been turned from acute pre-terminal illnesses into chronic illnesses that we can manage. And it's due to the efforts of people like my guest today, Dr. Stephen Chan. Thank you so much for being with us.
Thank you. It's my pleasure to talk to you.
Well, I hope you enjoyed that episode of Onc Now, our bi-weekly podcast. If you did enjoy it, please consider subscribing on Apple Podcasts or Spotify or wherever you get your podcasts so you never miss an episode. And please like us on social media and tell your friends and colleagues. And check out our archives because they're growing. And please join us in 2 weeks for another fascinating episode. Until then, I'm your host, Dr. Jonathan Sackier. Please, everyone, stay safe, stay well, stay curious. Bye for now.